The Construction Industry Council, CIC, is the representative forum for professional bodies, research organisations, and specialist business associations in United Kingdom construction industry. As the representative of the views of professionals, CIC has a seat on the governmental body, the Strategic Forum for Construction, and developed and operates the Design Quality Indicator tool to appraise the design quality of buildings. In 1999, the CIC and leading members of the industry agreed to address the issue of poor quality design in buildings. This action was supported by the Commission for Architecture and the Built Environment, the Department of Trade and Industry, the Office of Government Commerce, Constructing Excellence, and the Strategic Forum for Construction. After 4 years of development, DQI was the solution. DQI has 6 stages which are undertaken over the project's life cycle. In order to achieve excellence, ambitions must be set as a team and monitored during each stage. DQI and design appraisal should not be confused with the design review, which is an independent and impartial evaluation process in which a panel of experts on the built environment assess the design of a proposal. The panel also explores how a building or place can better meet the needs of the people by constructively endeavouring to improve the quality of architecture, urban design, landscapes, and highway design. Whilst the CIC's DQI process has matured over the last 20 years, the DQI for Health has only been available since 2014, when it replaced a Department of Health process called Achieving Excellence Design Evaluation Toolkit, or ADIT. Ironically, ADIT was based on the CIC's original DQI principles, but was dropped by the Department of Health in favour of a DQI designed specifically for the NHS. ADIT was carried in-house, often with limited stakeholders, and therefore the outputs were seen to be potentially biased towards design driven by a who shouts the loudest gets and want over need. It is apparent that DQI is an improvement on ADIT, both in content as an independent and facilitated staged process that provides formal assurance from the strategic outline case to the post-occupancy evaluation stage of a project. The role that DQI can play in a capital investment proposal for an estate development cannot be understated. When effectively timed, it supports key stages of design development, the business case production, and approval process. DQI also provides mutual support to other essential processes, for example BIM, BREEAM, and formal project review. Previous national DQI events have highlighted the links between DQI and BIM in the NHS business case, as well as between DQI and the Procure 21+/22 pre-tendered framework, where the significant work has been undertaken on repeatable rooms and standardised components, assisting NHS organisations in achieving improved quality and sustainable cost reduction. The DQI for Health was refreshed in 2018 and relaunched in 2020 to now include an additional assurance review for a project at each DQI stage. DQI for Health is a 6-stage process and is most effective when introduced into the project at project initiation stage and/or pre-strategic outline case. DQI needs early engagement to be most effective, and the pre-DQI assessment discussions take the opportunity to advise the project's senior responsible owners and other senior stakeholders of the process and the support required to reap maximum benefits. Stages 1, 2, and 3 are carried out at each business case stage, i.e. strategic outline case, outline business case, and full business case. And the outcomes from each stage's workshops are made available in a standard report by the CIC's DQI facilitator. The reports support the project at each of these stages and provide assurance to the NHS client organisation and all those reviewing and/or approving investment. Stages 4 and 5 are carried out post-construction to support early lessons learnt and any significant defects. Stage 5 is the post-occupancy evaluation. This slide illustrates how the DQI for Health outputs can inform design improvements for future projects, both for the client organisation and, more importantly, other NHS organisations considering similar projects. In this respect, the DQI for Health enables the integration of other estates standards and business case requirements, including design derogation and risk management, infection prevention and control, fire safety, and sustainability and net zero carbon. This slide highlights key areas considered in the DQI for Health 2 appraisals at each of the stage workshops and subsequent stage reports. A feature of the new DQI for Health 2 is providing client organisations with an assurance log on these key areas as part of the standard reporting process. From a design quality perspective, the DQI for Health 2 considers these three dimensions: functionality, build quality, and impact. Functionality, which includes flexibility and future-proofing, has three subsections. Access, considering the whole journey from where you start to the building, department, or room you need to get to. Space, concentrating on the amount of space in the building in relation to its purpose, how space is to be located, and people's movements around efficiently and with dignity. Uses, the way the building enables the users to perform their duties and operate the healthcare systems and facilities housed in the building. Build quality, this is supporting life cycle costing and operational management, and also links with the government requirement for BIM data and asset management. And there are three sections under build quality: performance, which refers to the performance of the building itself; engineering, the systems to be designed and used in a scheme; and construction, which is more than the process of building the building. It's a design approach involving the design team, constructor, contractors, and other specialists if appointed. DQI also considers the project's impact on users of the facilities, the local communities, and future project design. And there are four sections under impact. Urban and social integration. Healthcare buildings should become part of and enhance the local community. Internal environment, considering the comfort and respect of users, staff, and visitors, and their experience of the building. Form and materials, looking at how the exterior is designed and materials are used to enhance the overall experience for users and contribute to some important aspects of sustainability. Character and innovation. Character implies individuality, which enhances the building. Innovation implies new thinking and solutions. In the DQI briefing tool, every statement of the questionnaire is attributed a tag, either required, desired, inspired, or not applicable. The tags generate a graphical representation of what the participants would like the project to achieve. Default tags are set required and can change according to the project's requirements. Required means compliance with standards, regulations, and quantified minimum targets. Desired means setting targets for building performance beyond the minimum required. Inspired means inspiring goals and statements with reference to special buildings. And not applicable means it's not achievable or applicable for this project. This slide illustrates that the earlier in a project's life that design is appraised and agreed by the stakeholders of the client organisation, the less expensive it becomes to deliver. The earlier the DQI process is engaged with and stakeholders' consensus is reached, the easier it becomes for the client organisation to communicate changes in the project to architects and supply chain partners, to correct errors, mitigate risk, and better control cost. It's already been mentioned that stage 0 and early engagement is key to a successful project, as this provides the opportunity for the client organisation and the DQI for Health facilitator to determine the project's key stakeholders. It's encouraging that more organisations see patient representatives, visitors, and carers as important members of the stakeholder group. Over the past 2 years, there's been an increase in projects ranging from primary care, learning disability housing, mental health units, as well as general and specialist acute care that have benefited from this approach. Please note that this slide will not cover all who may need to be considered, as projects will always have their own unique characteristics. Each DQI workshop involves the facilitator taking the stakeholder group through the project's latest design, recording likes, dislikes, and suggested changes using a questionnaire developed and finessed over the life of the DQI for Health. Stakeholders are given the opportunity to discuss outputs and key areas from previous workshops. Depending on the size and complexity of a project, a workshop may be half a day or more than a day, and this is agreed with the client organisation prior to the workshops being arranged, to ensure all stakeholders can commit to the success of the workshop. Some NHS trusts have recently asked for more than one workshop at the early design stage, where they have particularly large and complex developments, which include various options still under consideration. The information from all stakeholder questionnaires is collated, and the assessment outputs are provided at each stage in a standard report format to support the project and provide an additional level of assurance to trust boards and approving bodies. This and the next slide give examples of assessment output indicators, which are included in the written report prepared by the DQI facilitator after each workshop. These take the form of graphs including raw data and weightings criteria used on the day. Once scoring has been input into the DQI platform, the assessment tool offers a range of different graphic representations of the workshop responses to the questionnaire, which are included and described in the facilitator's report. New to the DQI for Health 2 is a graphic similar to this. Its purpose is to show how each of the 10 DQI sections have scored against stakeholder expectation and other key project drivers, such as cost, following each appraisal stage. The new DQI for Health 2 output graph indicates the benchmark for future DQIs on this project to ensure all sections continue to improve at the later stages of design, construction, and operation. This graph was developed by the CIC and NHS England and Improvement to track the progress of the project through each DQI stage. Also new to the DQI for Health 2 is the project assurance log, which is completed at each stage by the DQI facilitator, the project director, and/or members of the project team. This covers key elements of the project for which assurance on compliance or not for the trust boards and other key stakeholders includes cost, estate strategy, sustainability and net zero carbon, travel plan, local authority planning applications and approvals, modern methods of construction, infection prevention and control reviews, fire safety reviews, design compliance and risk management, and BIM. I hope you have found this short presentation useful and that you now have a better understanding of the design appraisal process, where it should fit into your project program, and the benefits that can be realized throughout the whole of the project life in regard to design, quality, cost, and lessons learnt from other healthcare projects. If you would like to know more, please contact the DQI for Health team at the Construction Industry Council. We have also uploaded onto the CIC website a copy of the current NHS E&I Project and Business Case Activity Guide from January 2021 that shows how design appraisal is a key part to the overall project delivery process and programme. This is available under the link for this presentation. Thank you for listening.